Hey everyone. Hope you all had a great 4th of July weekend. Able to have some fun. Didn't have to study so much. If anyone has any questions, just throw it in chat. Okay. Fluid absorption and secretion in the small intestine. Let me pull up that stuff. Okay. So the big things to know about fluid secretion as far as the small intestine, make sure you understand the purpose of Brunner's glands and the crypts of Leberkuhn. Okay, Brunner's glands, alkaline mucus. So remember, that first few inches of that duodenum, first few centimeters, is going to be very, very acidic chyme coming from the stomach. So these Brunner's glands have this alkaline mucus to dilute and neutralize the acidity that's coming in from the stomach. The crypts of Leberkuhn, therefore, mucus secretion, keep everything lubricated and moving. Also helps with secretion of water and some electrolytes. So those are the two major things that are going on with the types of these goblet cells and the crypts and the enterocytes, what they secrete. The other important thing to know, we talked a little bit about the chloride channels. It's not going to be that important on your exam. We'll get to that a lot more in patho with regards to the chloride and how they get turned on with different types of diarrhea. It's not really a patho. It's more of a pathophys question than it is a physiology question. The other important thing to remember with regards to absorption in the small intestine, it's all tied to sodium. So you need sodium there in order for it to work properly to absorb the nutrients. Sodium is needed for that co-transport. So make sure you remember that sodium is the main ion for all the transport and uptake of all the nutrients and amino acids and glucose and all that stuff. Major topics to know, that's like everything. I don't know. It's I don't want to go through everything and just go through the entire lecture. But if there's not a lot of questions later on, I'll pull up some of the lectures and start going through. With regards to the GI system, like I said in class, as you're reviewing this, just go through each phase of where the food is. Starts in the mouth, what's going on in the mouth, or even before the mouth, the smell, getting the GI centers activated. Know what's going on in the mouth, what enzymes are released in the mouth to help with starting the digestion of things. Go down swallowing, the different phases of swallowing, esophageal transit, how long does it take, what's the purpose of it. Then you get to the stomach, what's doing in the stomach, what's the purpose of the stomach, what does it do, what hormones are released from the stomach. Then you go into small intestine, what's special about the first few centimeters of that small intestine with that duodenum, what happens there, what hormones are released from there, why would a hormone be released from there. Acidic chyme is coming into the duodenum, it's irritating it, it's going to cause the release of the other three major GI hormones that we talked about. So make sure you understand that. As you go further in the small intestine about the absorption of the nutrients, how does that work? Then move on to large intestine. What happens in the large intestine with regards to water and electrolyte balance? Know about the vitamins in the large intestine, what vitamins are being made by the bacteria. Then go through your liver, gallbladder, pancreas, what are they doing, and stuff like that. That's a good review for the GI system. These questions. So first question is about the renin cascade. You just need to know that renin is released from the macula densa in response to low effective circulating volume. You just need to know that it's going to make aldosterone at the end. Make sure you understand and you know what aldosterone's job is. Sodium reabsorption, potassium secretion. That's the end result, and we know that if we're going to reabsorb sodium, water is going to come along with it, and the end result of this is to increase your blood volume, which is in turn going to increase your blood pressure. Make sure that all gets in there. You don't need to know all the steps inside. Now, I will preface that by saying angiotensin converting enzyme is very important in the renal system. Make sure you know what type of arteriole the ACE has its effects. So we have your afferent, efferent arteriole. This is norepinephrine, and this is the ACE on that side. So make sure you understand that one. And the next question was about diuretics. Okay, let me go. So the diuretic one, what do I want you to know about the diuretics? So there were here's our Bowman's capsule. Here's our loop. There's our thick ascending loop. Let me go down. So this area right here, the thick ascending limb, those are the loop diuretics. Distal tubule, those are your thiazides. And finally, in this last area, these are your potassium sparing diuretics. The only one that we didn't really discuss a whole lot in class, and it's not going to be on your exam as an example, but in this early proximal tubule, these are the carbonic anhydrase inhibitors. But we really didn't talk about that a whole lot. Remember, for the loops and the thiazide diuretics, they are transporters. They're co-transporters with sodium, potassium, and chloride. And remember, the loop and the thiazide diuretics block the chloride from binding to the receptor, and the entire co-transporter shuts down. So I'll put it in a different color. Loops block the chloride, thiazides block chloride, potassium sparing alters aldosterone. And that's what affects that one. So those are the diuretics. Now remember also with regarding to loops and these thiazide diuretics, when you block that entire system, you have a lot of sodium that gets left inside that tubule, inside the filtrate. And all that sodium is going to eventually make its way to that cortical collecting duct at the end there. And it's going to have an effect there as well. So make sure you remember what sodium does there towards the end. What else we got? Okay. Biliary and gallbladder secretion. Cholecystokinin is going to be the big one for all that. Secretin does a little bit because, let me pull up the slides here. Hang on a second. Here we go, gallbladder. Yeah, so CCK is the really big one. Secretin also has a role as well. So don't forget about secretin for that one. The potassium sparing diuretics are mainly going to be at the very, very end, late distal tubule, common collecting duct right at the end there. All the hormonal things, which is mainly going to be aldosterone and ADH, are always going to have their effect right at the very, very, very end. All hormonal control, which is your fine tuning of your potassium concentration, fine tuning of the water balance, to either concentrate or dilute out the urine in order to change the osmolarity of the blood, all happens right at the end at that cortical collecting duct. Okay, while I have this chart up right now regarding aldosterone, so we know that normally the effect of aldosterone is going to cause, oops, let me change this. Now, normally what aldosterone does is it sodium reabsorption and potassium secretion, secreting potassium back into the filtrate, so it's going to lower the potassium in the blood. The drugs that we give are aldosterone antagonists, so they're going to block the effects of aldosterone. If I block the effect of aldosterone, the opposite occurs. I'm going to cause sodium secretion, or it's just going to stay in the filtrate. I'm never going to bring it back. I'm not really causing sodium secretion. I'm just not reabsorbing it. And by not doing that, the potassium stays in the blood. And because the potassium stays in the blood, it's considered potassium sparing because we're able to keep the potassium in the blood and we're not going to drop our potassiums. Thiazides and loops, because we block the triple transporter we're not going to bring potassium out of the urine back into the blood. We stop that whole thing from happening. So those you lose potassium because of the shutting down of the entire co-transporter. With the effect of aldosterone, it's considered potassium sparing because it blocks the effect of aldosterone. We're going to keep the sodium in the filtrate, in the tubules, in the urine. If the sodium stays there, the water is going to stay there as well. And with the water staying there, it acts like a diuretic. These are very weak diuretics. You don't give these types of things, potassium-sparing diuretics, to treat like acute heart failure. They're not going to be strong enough to work. You really need to give the loops or the thiazides. That gets a lot of the water off. But the aldosterone is more for maintenance type of thing for heart failure. But that's the effect of the aldosterone antagonist, the potassium-sparing diuretics. It blocks the effect of aldosterone, so the potassium stays in the blood. So they're considered potassium sparing. So Maria, if I need to go over diuretics more, let me know. I'm going to move on to renal regulation of acids. Okay, let me pull up my notes. So, acids. We are constantly acidifying the urine. Okay, remember we always talked about how we don't care about the acidity of the urine. We just want to get it out of the blood. We want to keep that blood pH in a normal way. So we have ways to get rid of acids. Remember, when we talk about acids, we are mainly just talking about hydrogens. We have to get a way to figure out a way to fix these hydrogens to something so we can get rid of them. One way to do it is the bicarb. We have, we'll put the lumen here. Here is the tubule cell. And then we have the blood over here. So what we're going to do is in the lumen, in the filtrate, we have the bicarb that comes in. In the tubule cell, one example, we're going to donate a hydrogen that's coming from the blood. We can get rid of it. This hydrogen will bind Okay, so that hydrogen comes together, brings our H2CO3, our carbonic acid. Now we have an acid that we are able to titrate, and then through the effects of carbonic anhydrase, we get H2O and CO2. H2O just stays in the filtrate, and the CO2 we can bring back in to the cell. Does a whole bunch of magical stuff inside the cell with a carbonic anhydrase, and the major effect is to dump in 3 bicarb ions. So this is one way we can get rid of that acid, is with bicarb. The other way we can get rid of the hydrogen is with ammonia. Okay, it's NH3. We can bind it to the hydrogen, NH4 plus. That just stays in the urine and it's gone. We can pee it out. So that's another way we can get rid of a hydrogen. The last one is the phosphate system. Okay, H2PO4 2 minus, or sorry, HPO4 2 minus, plus the hydrogen Same thing out here. The same process happens. We're just donating a hydrogen into the urine, further acidifying the urine, but getting rid of it out of the blood. So that binds to that, and that results in H2PO4 minus, and that just stays in the urine, and you just pee it out. So these are the types of ways these acids that we can titrate, we can attach a hydrogen to and get rid of. So that's the titratable acid stuff. Sure, I can live with the background. Okay. Okay, so I think I'm caught up now with questions. If anyone has any other questions, please let me know. But or further clarification of those things, let me know. One thing I will review is the effects of constriction and dilation on the afferent and efferent arterioles. So there's our afferent. Here's the efferent. In a normal situation, we have adequate renal blood flow, which provides adequate hydrostatic pressure of the glomerular capillary, which results in an adequate glomerular filtration rate. So remember, with the renal system, the GFR is really what we're trying to keep constant here, so we can filter out the blood. If we deal with the afferent arterioles only, so let's say we want to dilate it. Okay. So we dilate the afferent arteriole. What's going to happen to the renal blood flow in this situation? It's going to increase renal blood flow. More of it's going to be able to get in. We have more highway lanes open. More can get into the glomerular capillary, to the Bowman's capsule. That leads to increased hydrostatic pressure of the glomerular capillary, which leads to increased GFR. Okay, now let's set it up again. Now we are going to constrict the afferent. When you constrict the afferent arteriole, it decreases renal blood flow, which is going to decrease the hydrostatic pressure in the glomerular capillary, which is going to lead to a decrease in GFR. Also remember that the afferent arteriole is under influence of norepinephrine. Now let's talk about the efferent arterioles. Okay, first thing we'll do, let's dilate it. So when you dilate the efferent, renal blood flow is going to go down because it's going to pour out of the glomerular capillary. It's going to fall out too fast because the exit is dilated. So blood can rush out faster now. So it's going to decrease renal blood flow, which is going to decrease the hydrostatic pressure of the glomerular capillary, which leads to a decrease in GFR. Now, let's set up again. And now we are going to have the efferents constricted a bit. Okay, so we have constriction of the efferents. So the exit is now blocked. So the blood is going to start to pool up a bit inside this Bowman's capsule because the exit's blocked. It can't get out. So renal blood flow is going to increase. Leads to an increase in, hydrostatic pressure of the glomerular capillary inside the Bowman's capsule, which is going to lead to an increase in GFR when you have a mild constriction of the efferent arteriole. However, we also have another situation that can happen with that efferent arteriole as well. And this last one is extreme constriction. Okay, in this case, well, we can renal blood flow goes up because all this blood gets stuck inside the glomerular capillary. However, due to the extreme constriction, very, very, very little blood can exit the glomerular capillary. So you're getting a backup of all these things that are piling into that glomerular capillary. Well, one of the things that's going to be piling into all that is proteins. And proteins are going to exert their oncotic pressure. But in a case of extreme constriction, the oncotic pressure of the glomerular capillary goes up. Remember, oncotic is the suck. It's going to pull it back in. So, in extreme constriction, the oncotic pressure starts to exert a stronger influence. And when that happens, we get a reduction in GFR. This is the special situation compared to the other ones. These efferents are under the effects of angiotensin converting enzyme. The afferents, again, are under the influence of norepinephrine. So when it comes to these afferent and efferents, that's what's going on there. So make sure you understand that one for tomorrow. Okay, let me see if anything else in renal. You will not need to know the reasoning for the acid-base disturbances, but you will need to know which ones they are. So if I give you a lab value, know is it a metabolic alkalosis or acidosis or whatever. But you don't need to know like the cause. Hang on, I'm behind here. Hang on. I'm trying to catch up. So the renal blood flow, when you're thinking about it, we want to know where is it. The renal blood flow, what matters is what's inside the glomerular capillary, which is inside that Bowman's capsule. We denoted that thing right here. So This is the Bowman's capsule in here. The glomerular capillary is all wound up inside of this, and it comes back out. We were worried about what's going inside here. So the question comes in, when you dilate the efferent arteriole, I may have misspoken in class, I apologize for that. Less blood is going to hang out in here because it's pouring out of those dilated efferents. It's going to reduce the amount of blood that's sitting in there because the exit is wide open. The blood just going to fall out because the efferents are dilated. That's going to reduce the renal blood flow, reduce the hydrostatic pressure, reducing GFR. When you constrict it, then we're going to increase the amount of time that the renal blood is inside that glomerular capillary, because now we've constricted it. So it's going to hang out more, increase hydrostatic pressure, increase the GFR. Daniela, regarding the high effective circulating volume, it's basically just going to be the, let me just pull that slide up. For high, one is mostly going to be these baroreceptors, because they're going to release the ANP, the BNPs, to try and naturally naturese the patient, which is going to be a reduction of fluid by losing salt. That's why they're called atrial natriuretic peptides. Those are the big ones. The other ones don't really do much with the high affecting circulating volume. Okay, so next question is histamine. Histamine is released in the GI tract ECL cells. Let me just verify. I'm pretty sure it's ECLs. Where is it? Here it is. Yep, ECL cells. So it comes out of these ECL cells and has an effect on the cells that make the gastric acid. I just want to get the right picture. Here we are. The parietal cell. So histamine has a direct effect on the parietal cell to make more gastric acid. And that's the role of histamine. Mast cells create it, but okay, let me look at that renal blood flow in a second here. Let me just finish this last question here. Let me pull up the instructor copy. Hang on. Because that's right. Okay. Okay, so I had them confused. I had them reversed. Okay. Okay, let me redo these. I apologize for that, guys. Okay, so it's going to increase with dilation because it's probably wider so that they can flow easier. Decrease because it's not going to get through as much. That's why. Okay. Everything else is the same. Okay. The important part for these ones is to know what happens to GFR. That's the important thing with these afferent and efferent dilation or constriction. Understand the part at the end there with the GFR. Okay. So I apologize for the confusion on the renal blood flow. It is correct now. Like I said, the important parts is what happens this part. Which, did I mess that up too? Hang on. Yeah, everything else is correct. Okay. Sorry about that. Okay, so I apologize for that. Hopefully everyone's cleared up now. Okay. Make sure you understand the effects of ADH and what that does. Know how it's affected by the serum osmolarity, and make sure on the questions you read between, is it the urine osmolarity or the serum or the plasma? It will affect, so those are important as well. Let's see what else here. Make sure you know the definitions, filtration, secretion, reabsorption, excretion. Know that all I want you to know is that if you inhibit that, if you inhibit ACE, what happens? That's the extent of what I want you to know for those ACE inhibitors. Okay. ADH. Let me pull up that sheet here. Here we are. Okay. Water balance. So when we are water deprived, okay, if we are a water deprivation, we don't have enough water, the concentration of our solutes is going to go up in our blood, which leads to an increase in osmolarity of the blood. This increase in osmolarity is going to go to the hypothalamus, or sensed by the hypothalamus, which is going to do two things. It's going to kick in thirst, and it's also going to tell the posterior pituitary to release ADH. ADH is then going to go to the kidneys. And it's going to act on those V2 receptors. Remember, it is solute-free water that it's going to reabsorb. So it's going to reabsorb water until the osmolarity goes back to a normal range. Once it goes to a normal range, the stimulus to release ADH drops and ADH goes down. So that's what happens when we are water deprived. We don't have very, very much in the blood. We have to pull it back out of the urine. So therefore, the urine, decreased volume of urine. We're not going to produce a lot of urine because we need to reabsorb that water because we are dehydrated. Remember, the body doesn't care about the concentration of the urine. It cares about the concentration of the blood. So decreased volume of urine and increased osmolarity of the urine. So that's what's going to change with the urine. The urine osmolarity will go up to combat the water deprivation. On the opposite side of things, let's say now we have water excess. Okay, with water excess, now we have too much water, we're going to dilute the solutes. So the solute concentration goes down, which leads to a decrease in osmolarity of the blood, which means we have too much water. So we are not going to get thirst because we don't need more water in the system. We already have too much. And we're not going to secrete ADH because we don't need it. We already have too much water. So downstream, the urine increased in volume. We need to get rid of this excess water. Only way we can do it is by diuresing, and we pee it out. So we increase the volume of our urine, and it's going to decrease the osmolarity of the urine because all the water is going into the urine. It's going to dilute that out, lowering the osmolarity there in order to hopefully lower the osmolarity, raise the osmolarity in the body. So I hope that answers your question with regards to ADH. Let's see. Yes, so if you give an ACE inhibitor, you will cause that to occur. Because you can't dilate it anymore. You can't constrict it because you don't have the angiotensin converting enzyme anymore. We've inhibited the angiotensin converting enzyme. Therefore, we are going to have efferent dilation, and it's going to cause a decrease in your GFR, which again is why you don't want to give ACE inhibitors to people with chronic kidney disease because it's going to make their GFR even worse. As far as the other clinical correlations, only if I told you, yes, these are very important, make sure you know this one. But otherwise, the clinical correlations are there just to kind of like allow you to associate what we're talking about with something that you may have heard before. So sometimes those clinical correlations are there just to help reinforce certain things that we're trying to talk about with something that you may have already been experienced with. Okay, let's see what else in renal. Make sure you know the big one with low effective circulating volume. Make sure you understand the different ways we can raise our volume. And again, the main reason for increasing our blood volume is to maintain our mean arterial pressure. We got to keep that pressure constant, and when volume drops too low, we have to fix that to maintain our pressure. Okay, let's go over that sodium thing, what happens at the common collecting duct. But it has to do with potassium, I believe. So let's go to the potassium. I'm just trying to find that slide. Hang on. Okay. So we have our tube system. When you block, I'll just redraw it. Hang on. Okay. We have our loops here, our thiazides here, and we have our cortical collecting duct there at the bottom. When you block the co-transporters here and you block the co-transporters here, all this sodium that normally would be reabsorbed into the blood stays inside the urine, and all of this extra sodium travels the whole way and finally ends up towards this cortical collecting duct towards the end. When all this sodium travels and stays inside the filtrate and makes its way towards the end, there's a lot of sodium being delivered right here at the end. What this does is it drives further potassium secretion. And therefore, if you're secreting more potassium into the filtrate, you're going to decrease your potassium in the blood. And that's another way that you have hypokalemia, when you have an increased delivery of sodium to the end because of the diuretic use. Allows all that to happen. The big takeaway with first pass metabolism is that anything that you give orally, whether it's drugs, food, anything that goes orally into your mouth when it gets to the GI system, has to go through a first pass metabolism, so you're going to lose some of the quantity. So I'm not going to get much detail. You'll do all that with Dr. Wood with pharmacodynamics, but just realize that anything that gets absorbed goes to the liver first, then it goes to the entire body. That's really all first pass metabolism you really need to know. Okay, let's talk about micturition and how we go to the bathroom. Okay. The pons is where we have that micturition center, which kind of senses the fullness of our bladder. As our bladder gets bigger from storing urine, it starts to get bigger, it starts to stretch. As it stretches, okay, it sends signals to the pons and the micturition center and you start getting the sensation, hey, my bladder's full, I have to go pretty soon. So if we talk about the bladder, like a big hot air balloon, we have one sphincter there, and we have one more sphincter there. Main things to know. Parasympathetic nervous system is going to affect the bladder itself. That's called the detrusor muscle. Okay. It's going to stimulate it. So the detrusor muscle squeezes when you have to go to the bathroom. So the parasympathetic system is involved with that. It also has a little bit of an effect on the internal urethral sphincter. We also have sympathetic nervous system as well. And this also is going to go to that internal urethral sphincter. The internal urethral sphincter has alpha receptors. So basically what happens is normally it's under control, sympathetic system is going to be contracted. But when you have to go to the bathroom, the sympathetic system kind of like backs off a bit. The parasympathetic takes over just because the SNS drops off. And the parasympathetic system allows that internal sphincter to relax, allows urine to flow down. But then it's going to hit the external sphincter. And the external sphincter is a motor. So it's under voluntary control. Okay, that is what we can control when you have to go to the bathroom really bad and you're trying to hold it. We can control that external sphincter to allow the flow of urine when we need it. Okay, and make sure you know the innervations, yes, so make sure you know, hang on, that the motor is pudendal, parasympathetic is the pelvic nerve, and the sympathetic innervation is the hypogastric nerve. Okay, and those are the innervations for that. Next question is nitric oxide and ATP for digestion. Let me just pull up that slide. Okay. And there we go. Okay. Nitric oxide and ATP. Inhibiting the okay. Again, go back to a little bit more of your SNS, sympathetic nervous system. ATP, nitric oxide are usually going to be more stimulatory. So if you're in a stimulatory environment, you don't want your GI system to do anything. So by having it, ATP and nitric oxide being inhibitory when those things come out, it's going to make the GI system not work so that you can do your sympathetic activity first and get done with it, whatever it's going to be. So that's the it just don't go much detail as far as the why. Just know ATP and nitric oxide are inhibitory neurotransmitters in the GI system. Trying to think anything else. GI, kind of went over that already though. Just know the different phases. Just follow a piece of food throughout the entire system. It's the best way for that. Make sure you know all the indices that we look at for kidney function. Okay, low and high circulating volumes. I was looking for the slide. Here we are. Okay. So we have low effective circulating volume. What's going to happen to it? First thing, we have the kidneys. Juxtaglomerular apparatus is going to sense it. And we're going to get renin out, which eventually is going to lead to aldosterone release. And that leads to sodium and water retention. When you do that, the circulating volume goes up. What also is sensing it? We have our low pressure baroreceptors. So this is going to cause ADH to be released. ADH is going to do a couple of things. One, vasoconstriction. It's going to cause that. The other thing it's going to do indirectly also sodium and water retention. Remember, it's free water reabsorption. ADH is going to bring all that free water back in. The other thing that's going to happen, we have our high pressure baroreceptors. And what they're going to do is they're going to stimulate the sympathetic nervous system. Sympathetic nervous system is going to be activated. It will also cause vasoconstriction as well, decreasing the radius, increasing the pressure. It's also going to cause cardiac excitation, and with the main goal of increasing or maintaining mean arterial pressure. Vasoconstriction will also help maintain mean arterial pressure. Sodium and water retention is going to help maintain our mean arterial pressure. So these are the main things that happen when with regards to low effective circulating volume. With regards to high affecting circulating volume, now we have too much pressure in the system, too much volume. We're volume overloaded. CHF, renal failure, whatever it is. They have too much volume. Okay. The kidney does nothing. We have too much volume. It's not going to kick out renin. Nothing's going to happen. Our low pressure baroreceptors. These are going to sense that there's not a lot of volume or there's too much volume in the system. These low pressure baroreceptors are being activated too much. They don't like it. So they're going to cause the release of atrial natriuretic peptide. The effect of this is going to be a decrease in sodium water retention. Okay, so we're not going to absorb it back. We're going to keep it in the urine and just pee it out. So the low pressure one. The high pressure baroreceptors don't do anything. We already have high pressure. We're okay here. So it's going to reduce the sympathetic nervous system activity, which will, again, further reduce the renal sodium and water retention. But with the high pressure, the main thing is going to be that when you have high affecting circulating volume, the low pressure baroreceptors are getting stimulated like crazy and they release atrial natriuretic peptide. And in order to natriurease the patient by losing the sodium, has a mild inhibitory effect with no renin, no aldosterone, so therefore nothing's really going to pull in that sodium anymore. So it's an inhibitory effect, but it's just not that strong. It's not a direct effect. It's just that with the high circulating volume, we don't need the renin, therefore there's no aldosterone, nothing really helping that sodium and water retention. Okay, we're caught up with questions as well. Make sure you also know the gut-brain axis, what type of nervous system sends signals to the brain. Like what does the parasympathetic relay to the brain regarding the GI system, and what does the sympathetic nervous system relay as well, and how they go back and forth. So make sure you know that ones as well. Okay, any other questions? I'll stick around for a little bit more. Make sure you know all the ways that potassium can get sequestered. What drives into the cell? Okay, so what goes into the cell drives it out. Make sure you know the acidosis and alkalosis. When you say percentages and values, do you mean like what percent is reabsorbed in the earlier parts versus the later parts? You don't need to know those ones. Remember, the bulk of all the reabsorption always occurs in the proximal tubule. Early on, all the fine tuning occurs late distal tubule, common collecting duct. What was I going to say? Also, remember that potassium acts funny when it comes to that cortical collecting duct, that it can adjust that fractional excretion real big extremes depending on what's going on in the blood. Regarding deglutition, just understand the 3 phases of swallowing. Know which ones are voluntary, and you don't need to know all the cranial nerves that are involved in swallowing. Just make sure you understand the 3 phases. Okay, acidosis and alkalosis with regards to potassium. Okay. So first of all, remember that in the CCD, we have a hydrogen potassium exchanger. So we have this exchanger. So depending on what's going on in the blood, we either need to get rid of a lot of hydrogen or we need to bring hydrogen back into the blood to buffer everything out. So just think about hydrogen. Where is hydrogen got to move? If we're very acidic in the blood, the hydrogen has to go into the tubular fluid or into the cell. If we are in an alkalotic environment, we have to bring the hydrogen out. So the potassium is going to get drawn inside. So with acidosis, hydrogen is driven inside the cell. When it goes in the cell, potassium comes out. So acidosis leads to hyperkalemia. If you have alkalosis, we need to get the hydrogen out. We got to buffer all this stuff. Okay? So hydrogen exits the cell, and potassium goes into the cell. We have this exchanger going on. So alkalosis, now we're driving potassium into the cell. Alkalosis causes hypokalemia. Now, do not get this confused and go the opposite way. The potassium doesn't cause acidosis or alkalosis. It's the alkalosis or the acidosis that causes the issues with the potassium. It's not the other way around. It only goes one direction. The acidotic or alkalotic environment of the blood alters the hydrogen. The potassium is just a consequence of the exchanger. So not much happens, and that's why you have these directions where they're going. So acidosis causes hyperkalemia. We got to get those hydrogens out of the blood into the cell, and potassium gets kicked out into the blood, so potassium goes up. In alkalosis, we need those hydrogens out of the cell to help buffer that out. So hydrogens leave, potassium go into the cell or driven in, and you get hypokalemia with alkalosis. So I hope that answers your question with that one. Remember, another way to get to lower, if we had high concentration of potassium in the blood, we give insulin, because insulin is going to drive potassium into the cell. So that's when you give insulin. Insulin is another way to get potassium into the cell. Any other questions? I'm trying to think. Acid base, you guys should be good by now with all that stuff. Okay, what time is it? The majority of magnesium reabsorption is going to be in that distal tubule. Let me pull up that slide. Thick ascending limb and the distal tubule is where the majority of magnesium is. Yeah, not the proximal convoluted tube, just the distal. So because it's a thick ascending limb, what kind of diuretic is going to cause problems with it? And also that distal convoluted tubule, what diuretics are going to cause issues? Your loops because of the thick ascending limb and your thiazides because of the distal convoluted tubule. So when you give those type of diuretics, you're going to have issues with magnesium and calcium as well. They affect both of them. Yep, we're done loop diuretics. Because the loops hit the thick ascending limb, so anything in that thick ascending limb is going to be under the effects of a loop diuretic. Anything that's being reabsorbed, secreted, going on in the distal convoluted tubule is going to be under the effect of the thiazide diuretics. So thiazide diuretics are going to cause not an increase, a decrease. No, I'm sorry. Stimulate reabsorption in the distal tubule. Yeah, so Noel, you're right, the way you wrote it. Actually, we give thiazide diuretics for people who have kidney stones that are based off of calcium. By giving thiazide diuretics, it allows more calcium to be reabsorbed, so less calcium will be in the urine to precipitate out to cause stones to form. So that's a way to give thiazide diuretics to kidney stone patients who have chronic kidney stones, not just one. But if they have chronic kidney stones or recurrent kidney stones, give thiazides to help the calcium reabsorption so less calcium is in the urine. Daniela, it is not the opposite effect. The sodium is the main driver of a lot of those things. The potassium won't cause issues with the sodium in that direction. Um, I mean, a lot of them get reabsorbed in different segments of the tubules. The bulk still happens for some of these. The sodium, the bulk reabsorption occurs in the proximal tubule for the sodium. We mentioned a lot of the magnesium is bulk of it is in the thick ascending limb in the proximal or the distal tubule. You kind of have to go to that chart to see the different percentages where the bulk is absorbed. Depends on which ion you're talking about. And calcium is mainly thick ascending limb and distal tubule as well. Calcium we'll deal with a lot more tomorrow when we deal with endo. Okay, filtered load and excretion rate. Okay, so the filtered load is everything that's dumped into that Bowman's capsule. Whatever's dumped, that's our filtered load. The excretion rate is what shows up in the urine. So, if the filtered load is greater than the excretion rate, so if the filtered load is 100, we're only able to excrete. Let me just pull this up, make sure I'm right here. Where is it? Where is this? I'm trying to find that slide on it. Here we are. Okay, if the filter load is greater than the excretion rate, there's 10 units that are left over. So we had to absorb it. We reabsorb it because we dumped in 100 units And the excretion rate was 90. So obviously 10 we brought back. If the filtered load is less than the extraction rate, that means that if you dumped in 90 units in the filtered load in the Bowman's capsule, but in the urine, there was 100 units of that substance or whatever it was, more of it got there. Where did that extra units come from? We had to have secretion of that ion or whatever it is. Remember, secretion is anything that's being dumped into the tubular fluid outside the Bowman's capsule. So if we're peeing out 100 units of something we're only loaded in 90, more of it had to get dumped in there. So there had to have been secretion somewhere along the way. Yep, Jonathan, you're right. And then the last thing that we talked about was just the fractional excretion, which if we filtered in 100, took out 90, what's left over, we figure out the percentage from there. So that's the fractional excretion, which is the last little bit. It's just a percentage. Mm-hmm. Any last minute questions before we sign off? Okay, I don't see any more questions, so we'll finish up tonight. I'll see you guys tomorrow morning. Good luck studying. You guys will do fine. This is a lot more straightforward than the cardio was. So I will see you guys tomorrow morning. Have a great night. Get some rest, some sleep, and I'll see you all bright and early. Have a good night.